Good morning, good afternoon, good evening, everyone. And thank you so much for once again joining us for one of our webinars of ADI. It feels like it's been a long time, not that long ago, but it's the first one of 2022. And what a topic it is today. About telemedicine, and I'll tell you a little bit more about it in a minute. I'm Paola Barbarino, the Chief Executive Officer of Alzheimer's Disease International. Next slide, please. About ADI, just a few words. We were established in 1984. We're the umbrella organization of Alzheimer's and Dementia Association around the world. We represent about 125 countries. And we represent you all at WHO, at the UN, and other international and regional bodies. We are the promoter of World Alzheimer's Month and the publisher of the World Alzheimer's Report, and many others. Our vision is to prevent, care, and include today, because hopefully tomorrow we may have a cure, but we don't quite right now. Next slide, please. And just a little note to remind you all that from the 9th to 11th of June 2022, we'll have our 35th Global Conference in London, and the early bird registration is now open. This is the oldest Alzheimer's and Dementia conference in the world running today. Next slide, please. Now, it's a difficult time right now. 1 in every 70 people in the world are impacted by crises at any moment in time and urgently need a system. And in times of crisis, often people with dementia don't get the support they need. And in 2019, we wrote a report about this, Forgotten in a Crisis, which you may be interested in reading. Most lately, we have been responding to events in Ukraine. We've developed a resource page that includes specific resources for Ukraine and the region, but also for anyone else facing a crisis. You can see the page below. I should add that from tomorrow, new cards and infographics on to be of help to humanitarian agency and NGOs and people living with dementia and carers will be available from tomorrow. Next slide, please. Also to remind you that we thank all of you that have contributed to ADI in the last many years, and especially in the last 2 where it was so difficult with COVID. And to remind you to help us with donations when you can and if you can, and thanking you all. Next slide, please. But without further ado, let's start with the speakers for today. Professor Henry Brodaty, the Scientia Professor of Aging and Mental Health at the UNSW and co-director of the Centre for Healthy Brain Aging in Australia. Henry doesn't need any introduction. He's also one of our past chairs. He will be joining us from Australia, so pay attention to the time zone here because we got time zone really all over the world today. Dr. Ismael Calandri, behavioral neurologist and statistician at FLENI in Argentina. Dr. Maiya Geddes, assistant professor, Montreal Neurological Institute, McGill University, Canada. She's the one with the earliest wake-up time today. Dr. Mina Chandra, Head of Department of Psychiatry and Center of Excellence in Mental Health at the ABVIMS, and Dr. Ram Manohar Loyal Hospital in Delhi, India. And finally, Dr. Temitope Farombi, consultant neurologist at the in Nigeria. Now, I do understand that we may have a problem with Dr. Farombi joining us. She's the last speaker, so I will update you at the end of the webinar if there are issues. I think Temitope may be online now, so we should be fine. Now, next slide, please. Before we start, and we also have one other contribution I should have added in the speakers. The speaker in question will not speak live. She has asked to remain anonymous, and I will read her contribution at the beginning of the webinar. But before we start, we will start with some polls. This is to gauge your interest and temperature around the issue of telemedicine. So Jane will now run a couple of polls. The first one is, have you ever used telemedicine in your practice or been on the receiving end of a diagnosis or care or support work via telemedicine? Yes or no? We will leave you a few seconds to reply. If you could, that would be wonderful. Thank you very much. And I should tell you, whilst you vote, that today we have 78 countries joining us, a truly international workshops Thank you to all of you that are joining us from very difficult timelines. So the result of the poll is that yes, about 57% of you do use it and about 43% of you don't. So I really do hope this webinar is going to be of use for all of you. We'll close the poll now and we will run another poll. So about acceleration or prevention of telemedicine. In your experience, has COVID-19 accelerated or prevented the use of telemedicine? This is a single choice again, yes or no. If you could express your vote as we speak, just a few seconds to do that. And then we will be able to have a look at your replies. Yes, 88%, no, 13%. So yes, it has accelerated or prevented the use of telemedicine. That's going to be very interesting to see as we talk. I mean, to us, in our experience at ADI, there's been a lot more use of telemedicine during COVID-19. What we're trying to establish today is best practice and also issues where people have found the use of telemedicine actually difficult. So I will now ask for the next slide. Thank you, Jane. And I am going to read for you the personal story of Joanna, who has had a diagnosis of dementia online very recently. So if you bear with me a second, I seem to have a technical problem myself. That happens, unfortunately, also to us. So I am going to recall my I'm really sorry about this. I seem to be having a problem with this. There we go. So this is the testimony of Jo. She says, I had noticed memory issues as I hit 51 and had an appointment with a GP and an MRI scan just as the pandemic started. In 2021, I had another MRI scan and a referral to a cerebral function unit at a hospital. As we were still under lots of COVID restrictions, I conducted the memory test over Zoom. This took about 3 hours and was fine. Doing this online didn't bother me at all, and the doctor was helpful. 6 weeks later, I was asked to do an online consultation with another doctor who had then analyzed the latest MRI scan and the memory test. At the time, I was on holiday, which is not the reason I was on Zoom, and I don't think the doctor knew that I was where I was. As it was happening online, we assumed it wouldn't be bad news, and to be honest, it hadn't even dawned on me that any form of dementia could be the reason for my memory issues. I assumed it was related to the menopause. My husband was out for the day with my sons and daughter, and I stayed in the villa to do the call. The doctor was nice, and I think she was more subtle about the diagnosis, but did say that although it was semantic memory issues, they had identified it was progressive and a neurodegenerative condition that would turn into semantic dementia. If I am honest, I still didn't believe that I had dementia, but it did cause a huge amount of shock for me. And the knock-on effect for my husband was huge when I phoned him after the Zoom call to tell him what I had been diagnosed with. The fact that there was literally no treatment, medication, or cure was the other huge shock. The next few days of our holiday were difficult. Neither of us could get our head around it, and we didn't want to ruin other people's holidays, so we didn't tell our children or friends who we were with. We asked for and had a follow-up call with the first doctor who had done the memory tests for me, which helped us to understand it a little. We were promised the real-world appointment with the doctor who had diagnosed me later that year. We saw the doctor a month later, and that was when the penny really dropped. One thing I felt I missed from the online consultation was reality. Until I was diagnosed in the hospital by the doctor in the same room and with my husband present, I was in denial. When I was with another doctor who knows me well and treats me with HRT, I told him my news, and this kind man hugged me. That kindness helped me. I have no criticism of the doctors from the cerebral function unit, but with hindsight, I don't think the online diagnosis helped me. As I have said, reality for me needs face-to-face interactions. Now, I leave you to reflect on this really important personal story, and I thank the person who has written that for wanting to share that with us. We are about person-centered care at ADI, and the view of the person that receives the diagnosis, that receives treatment, is the most important there is. So thank you so much for doing this for us. Now, I will ask now Jane to move to the next slide and introduce you to Professor Henry Brodaty, to whom I give the floor. Henry, the floor is yours. Thank you. You may need to unmute yourself.
Thank you. So thank you very much, Joanna, for your story and for telling it as you have. It's a good reminder of the limits of telehealth. I'm going to start by telling you about two examples that happened to me. I'm in Sydney, Australia. We had quite severe lockdowns, and nursing homes in particular were locked down because there were big outbreaks there. So the first example is a good story. It was a patient I was seeing who had dementia, and she was depressed, and I was asked to assess her. We arranged to do it by telehealth. I logged in, and the patient was in the room, her family was there, the nurse was there, the nurse had the medication charts and the file, and the social worker was there as well. Everybody was in the room at the same time. It was really efficient. I could talk to the patient, I could get all the information, and it worked beautifully. That was example one. Example two. This was a man who was also in a nursing home and had been aggressive. He had some hallucinations. He couldn't watch television because he believed that the television was actually real. He certainly didn't want to look at me on television. He had some hearing problems. English was not his first language. There was a lot of problems with a nurse getting a computer to start this, so we all started late. It didn't work at all. It was terrible. And so there are two examples of working badly and working well and working badly. So I've been using a lot of telehealth. I've been seeing people now for 2 years, and there are a lot of pluses and there are minuses. And let me just run through those. It's certainly convenient. I don't have to drive to work, or if I'm doing home visits or nursing home visits, it's even easier. I can do it all from my home. And as long as I'm wearing a nice shirt, I can wear my shorts and my sandals, and no one knows, right now, no one knows what's happening beneath the desk. It's very good for patients who are geographically distant. Australia is quite a big country, and I'm sometimes seeing patients in quite distant places. So it works well for that. Of course, the biggest driver for telehealth has been COVID. Who used Zoom? Who used all this telehealth and video conferencing beforehand? Well, I did somewhat, but it's just ballooned enormously. I have some patients who will not come to see me at the hospital because hospitals are dangerous places. You can catch COVID. They would much prefer to see me on telehealth. Another advantage is, as the first patient I told you about, everyone was gathered together. And it can be very time efficient. But there are negatives. So let me just run through those. My people I try and help are older. I'm a professor of old age psychiatry, or aging and mental health. And about 30% or higher of people who age over 65 are having hearing problems. About 30% having vision problems. Of course, this makes it much more difficult when doing it by computer. many older people are not technologically adept. Now, we've got an inkling that Joanna may be in her 50s, because she mentioned the menopause. That group are pretty adept. But the people who are over 80, not so adept. And often they need someone with them to be able to navigate the system. And people have different computers, often pretty old computers, and not supporting some of the more modern platforms that we use for telehealth. At the hospital I work at in Sydney, we are asked not to use Zoom because it's not confidential. We are asked to use a different platform. It was called Perplex, but now it's changed to My Virtual Care. And it means that people have to navigate a new system, log on, put their details in. It's an extra step. And often they fail, and I say, let's not worry about it. I'll send a Zoom invite, and we'll risk the confidentiality being compromised. It's never happened, but people can Zoom, bomb Zoom, and into your conversation. So there is some issue about confidentiality. The other issue is unstable internets. As we all know, we've been on calls and suddenly somebody freezes, or their voice vanishes, or their picture vanishes. And this is quite disruptive for the assessment. When I'm seeing a new patient, particularly for dementia, I like to do a physical exam. I like to do a neurological exam, check their heart, their blood pressure, etc. Well, clearly I can't do that on telehealth. So that's certainly a limitation. Joanna mentioned she had 3 hours of cognitive testing. I am amazed. I mean, I do a pretty brief test, the MOCA, the Montreal Cognitive Assessment. Normally that's 30 items. There is a telephone MOCA or blind MOCA that you can use, which I do use, which is only out of 22 points, but it's much more limited. And you don't get the same feel not doing it in person, because it's not just doing the cognitive testing and getting the score, but qualitatively how they're attacking it. And many people, if you look at the left bottom right-hand corner of your screen, not while Zoom's on, you see the date shown right there. And some of the questions we ask in cognitive testing is what's today, what's the date, and so forth. So it compromises the cognitive testing. I have never given anyone a diagnosis on telehealth. I think it's such a sensitive issue. And I actually was pleased to hear what Joanna had to say about that. I think it's so tough on a person not to be able to do that with them in person, to monitor their emotional reaction, to look to the other person they're with to give support. And often you want to talk to people together. And that can be hard on Zoom. It can be easier as well. And it can work in reverse. When I'm seeing a patient for the first time, I like to see the patient by themselves. And then I like to see the family member by themselves. If they're both sitting in front of the computer, it can be very difficult to arrange that when you're doing it by telehealth. And then finally, it's the issue of access to records. At the hospital, I can have the hospital record with me, or I can go onto another link and go into electronic medical records and see all that, or look at the x-rays. That's very hard to navigate when I've got my attention focused on looking at the person on the screen. So let me summarize. I think telehealth has been advanced and it's here to stay. There's no doubt we'll continue to use telehealth. And particularly for people in rural and remote areas, it's been a boon. There are some environments where it can work really well and not well, and that was the nursing home I gave you at the beginning. There's always a problem with people who don't speak the native language that you're talking in them with. So having an interpreter, it's possible to link more than one person in on telehealth, but it's a pretty complex operation, even in person. And by Zoom, I think it just becomes almost impossible. The other specific issue is dementia. It can be very confusing for many people who have cognitive impairment to see a person on screen. One of the commonest symptoms or psychotic symptoms of dementia is misidentifications, where the person believes what they're seeing on the screen is real. So if they see a fire, they may get a bucket of water and try and throw a bucket of water over the television because they think it's real. So this can be very confusing when they're seeing you on television. And the final thing I'll say from the provider's point of view is that reimbursement may be an issue, because we have separate item numbers for rebates in Australia, and there has been special dispensation to provide reimbursement during COVID. Whether it continues, I don't know. But in some countries, it may be you only get reimbursement if you see the person in face-to-face. So that can be a disincentive for some providers in seeing people. So in conclusion, telehealth is here to stay. There are challenges, there are some advantages, and I think we're getting better at how to deal with them. And we need to pay special attention to the needs of people with dementia. Thank you.
Thank you very much, Henry, for this very insightful presentation delivered in record time as well, and for picking up from some of Joe's point earlier. Now, can I remind every participant that we were going to pick up questions at the end of these sessions, and if you would like to be so kind as to write them in the Q&A box, whilst you can introduce yourself in the chat line if you so wish. Now, I hand over the floor to Dr. Ismael Calandri from FLENI in Argentina. Ismael, the floor is yours. You may need to unmute. Yes.
Oh, sorry. Hello. Today, we're going to talk about teleneurology in Argentina and how we face COVID and all problems. And are you seeing my presentation now? Maybe
maybe we can advance the slide.
Okay, perfect. Now, so let's talk why we talk about not so new challenges in telemedicine. Well, let me explain. Just wait for a moment. Let me show some data about Argentina. Argentina, it's a huge, large country, and we have, as you see, most of the population, if you see on the map on the left, we have most of the population surrounding a small area, but we have also clusters of populations all around the country, very far from this region. And if you see the deprivation index, that it's a composite to measure access to health, access to top water, you can see that this circle area is going well, that the rest of the country and the capital city, that is this blue spot here, it's doing very well. That you can say, okay, this is a problem with population and density and access to health. But if we correct, if we adjust for that and we see the number of neurologists per 100,000 inhabitants, you can see that Buenos Aires, or capital city, has almost 1.1 neurologists per that amount of subjects. And the second region, that is Córdoba, has the half, and the overall average of the country, it's around 0.1. That represents that there is a lot of communities living very far from the neurologists, and they have to travel for more than 1,000 kilometers to receive neurological care. And with this prior scenario, COVID came, and you know a lot of things about COVID, but I want to show you some local data. This is a small paper that we published at the beginning of the lockdown, the last year. And as you can see, with the lockdown starts in Argentina, neurological consultations drop for more than half both in outpatient clinics and hospital admissions, but the most drastic scenario happens in emergency department of neurology. If you see these charts on the left, in blue line, you can see the expected number of consultations per day in our emergency department, and in the purple, the reality, and you see we have a huge gap. And if you compare with COVID cases, because we had a lockdown very early in the pandemic, we lost a lot of patients even before that our emergency department got flooded of COVID cases. And what that represents? That represents, if we saw this paper from us that we analyzing the mobility of people in Buenos Aires, that people stop visit clinics. If you follow up the blue line that represents the movement around emergency departments, and never came back when the time goes forward. That doesn't happen with groceries, workplaces, and residential mobility. And that's also represent really impact in the health of demented patients. If you see this paper in which we put data from Argentina, Brazil, and Chile, demented patients during COVID pandemic get worse. More than 50% represents mood changes, more than 50% represents impaired in functionality. And if we ask to family caregivers, more than 60 and 70% reported an increased burden, worse health, and greater physical effort. So people stop visiting their neurologists and they are not well. So with this scenario, how we can solve or how we can help. Let me show some local response that we create. We created a small app to have medical consultations online. This app has the ability to be implemented on computers and cell phones, because that was a problem. Not everybody has a computer. This is a picture of my consultation, and we are giving dementia diagnosis in that way. And we ask our neuropsychological team to work in an adapted assessment battery to implement by online. So that we create this battery that is called FLENI ECAD. With all these methods, we try to help our patients and we try to help the regions too. Due to that, one of our goals was to do this FLENI ECAD moves global. So we create a platform to distribute it in other centers. We create training sessions for neuropsychologists, and we have a common data set to solve problems. Currently, we have around an average of 50 assessments monthly using this method, and 40% of centers, neurological centers in Argentina are using our battery. But we believe that provide an adaptive assessment battery is not enough to improve the teleneuropsychology implementation. So we came with a board of experts all around Latin America. We put together people from 18 countries, and we asked which problems do we face in teleneurology in Latin America and how we can face it. And we create several recommendations about that. And we published this paper that I personally recommend, because we came with solutions that could be implemented in another lower and middle income regions. And just to finish these presentations, I want to show you some results. At the same time that with the pandemic, the telemedicine consultations grows drastically, we have this situation. If you see these two maps, we have in the map on left, we have the density of addresses of our patients that are in-person patients. So we are places in this blue spot, as I told you, and people has to move far from that to see their doctors. And if you see 2020 map, these are the addresses of telemedicine consultations. And we have a lot of patients now outside Buenos Aires, and we have reached regions that we never thought before, and it's people not moving. And just to finish, I want to know these both mapped together, and we are now reaching regions with very low deprivation index. So we have difficulties, we have advantages, and we have disadvantages, but telemedicine could be a good gun in this war against disparity in our country. That's all. Thank you very much.
Thank you so much, Ismael. This was a brilliant presentation introducing us to this really important concept. One of the reasons why we're doing this webinar, in many countries, the availability of specialists, of neurologists, psychiatrists, of geriatrician is so limited, as well as we pointed out in the World Alzheimer's report last year, of diagnostic equipment. And so to see with such clarity the difference that it can make on a country of the territory extension as Argentina, where it would be really difficult to reach out to people affected, is wonderful and really can be transformative. So thank you for this. I'm sure there will be questions about it. And now I am passing the floor to Dr. Maiya Geddes, who is at McGill University, Canada. McGill is also the author of last year's World Alzheimer's report and next year's one, this year, for coming year, on post-diagnostic support. So Maiya, the floor is yours.
Thank you so much. It's wonderful to be here. So I'm just going to advance my slide. Here we go. So my name is Maiya Geddes. I'm a neurologist and a scientist at McGill University. I work at the McGill Research Center for Studies in Aging and also the Montreal Neurological Institute. I have no disclosures. So the goal today is to talk a little bit about current practice. So thinking about some of the ethical and technical considerations for remote cognitive assessment, and also to go over the multidimensional framework for remote cognitive, affective, and functional assessment that we developed during the COVID-19 pandemic, and just to end on some future directions and considerations of where this field is going and what work still needs to be done, because there is quite a lot to be done in terms of the validity and barriers, and specifically patient outcomes and experience regarding remote cognitive assessment. So this work really was born at the beginning of the pandemic, when the Alzheimer's Society of Canada convened a task force on dementia care best practices for COVID-19. And I led a work group on remote cognitive and behavioral assessment. We published our framework, and this was really convened under the auspices of the Alzheimer's Society of Canada, and we brought together a multidisciplinary team of experts, including persons with lived experience, geriatricians, neuropsychologists, neuropsychiatrists, and behavioral neurologists, to sort of come up with this multidimensional framework of how to approach, in the telephone and video conference setting, diagnostic assessments in individuals with cognitive impairment. One of the most important centers of this work is really the importance of the triad between the patient, the clinician, and critically an informant or care partner with the patient. And the goal here is really to maximize patient privacy and minimize the caregiver burden, because we're shifting this new burden to caregivers to actually set up the video conference environment. So how can we better address that? And ensuring that clinicians, patients, caregivers have access to technology and comfort using it, and also access to training. So at McGill, we provide, through the dementia education program, webinars for patients on what to expect during their telemedicine visit before they actually come for a visit. So at the center of this work, informed consent, informant history, and attention to privacy and autonomy are paramount. So when we think about an approach to the neurological or the clinician diagnostic assessment, there's some considerations before, during, and after. And at the center of all of these are ethical decision-making. So engaging in the question of for whom and when to use this, and specifically when not to. So if there's any question, sometimes the best option is to defer or to not conduct a diagnostic assessment remotely. In terms of some of the ethical considerations, really the same ethical principles apply to telemedicine as they do to in-person encounters. And fidelity is at the center of this. And what that means is that the interests and welfare of the patient really come first. Because there are limitations to the telemedicine diagnostic assessment, we have to be very transparent and disclose these and the rationale for why we're conducting a telemedicine interview with patients and families beforehand. And clinicians really need to feel comfortable with handling imminent risk that might happen in this environment. Strategies to minimize obtrusiveness, so offering telephone when it's possible or an in-person assessment if it's preferred to video conferencing also needs to be considered. And website training, so the understanding of verbal and non-verbal cues conveying empathy are really important because these are correlated with patient outcomes, and patients rate telemedicine poorly in one domain, which is the lack of touch. So it's really important to actually have this website training for clinicians. And some of the logistical and technical considerations when you're setting up an interview and during the interview is making sure that there's an encrypted platform and that patients have access to a quiet private room without backlighting. So we need to know who else is in the room with patients when we're video conferencing or on the telephone with them. Is this a multi-dwelling environment? Making sure cues are hidden and that family members or care partners don't prompt patients with answers which would render the diagnostic assessment invalid. And really optimizing the sensory input and output, so making sure the audiovisual setup is adequate, patients have access to their hearing aids, glasses, and there's a plan in case of technical failure. So always getting a phone number as you start a video conference assessment is really important, and then using screen share to share materials. In terms of during the assessment, the way that we make a diagnosis is really hinging on the convergence of information across the clinical history, which is the story that patients and family members give us about the course of their illness, and validated but brief remote cognitive testing, so either a cognitive screening inventory or domain-specific tests. And an importance is integrating affect and functional inventories with this. And we have adapted, and we review this, a remote neurological exam with some limitations, but there are some abilities to conduct a modified neurological exam remotely. So one piece that needs to be considered in the diagnostic assessment is really understanding neuropsychiatric symptoms. We often will use the mild behavioral inventory checklist, making sure that we're screening for affective disorders, and these can be provided and are widely, these are a number of questionnaires that are widely used and can be provided remotely for family members and patients before the interview, and also screening for functional abilities and for sleep. So as I mentioned, there's two different ways to conduct a diagnostic interview. Information can be gathered either by telephone or video conference, where video conference is preferred, but a number of telephone measures have been used and shown to be adequate in comparison to in-person assessment. One of them that's most widely used is the telephone interview for cognitive status, which has good sensitivity and specificity and is very correlated with other measures that are commonly used. But there's some disadvantage, like there may be a cultural bias, and it's unknown what the role of this measure might be in the diagnosis of more mild disease like mild cognitive impairment. And there are multiple preparations of the Montreal Cognitive Assessment, the Montreal Cognitive Assessment blind, which can be done via telephone, the five-minute protocol as well. And for a more comprehensive telephone assessment, SAGES, which is 30 minutes, has also been used and shown to be very similar to an in-person assessment. When we're conducting via video conference, a few things to bear in mind is that when we're using, we want to really use tools and measures that rely more on verbal responses than motor responses. So things like clock drawing have a little bit of a lower relationship between in-person and video conference assessment. And we have to be careful when we're dealing with individuals who are older or slower internet speeds, or people who are scoring closer to cutoffs or have more severe disease. These tend to be a little bit less reliable in the video conference environment. And here are a number of assessment tools that can be used. The Roland Universal Dementia Assessment Scale has a little bit less bias across sex, language, and education, and so may be more valid for linguistically diverse populations. We also propose a dashboard approach, so a domain-specific, so actually choosing selected domain-specific measures across cognitive domains such as attention or memory or language and visual spatial functioning and so on. So we use this sort of dashboard approach, or one can select sort of screening measures as an alternative. In terms of continuity of care, this is a really important piece. So when we're conducting a diagnostic assessment via video conference or via telemedicine, what happens next is really critical for the well-being of the patient. So when you're conducting assessment, it's really important to communicate very clearly to patients and families what will be the next steps, and the clinician really needs to be accessible for future guidance to create a medical record, a copy of which could be shared with the patient and also their caregiver, as well as their family physician and their multidisciplinary team. Support for patients and caregivers following a difficult diagnosis is really important and can be facilitated by providing educational materials, social work referrals, and now there's some really excellent community resources. We use FirstLink, for example, through the Alzheimer's Society of Canada to help patients link with others and to provide support after a difficult diagnosis. This field is really quite dynamic, as has been mentioned. Telemedicine is not going away regardless of what happens with the COVID-19 pandemic. I really think of it as a complementary tool. So I think of this as a training that actually neurologists, and I'm the director of the McGill Fellowship, Cognitive Neurology Fellowship Program, and we're offering training in this as a separate skill. But there's a lot of work needed to be done about the validity, barriers, and outcomes of remote cognitive assessment. So for whom should we use it and when? There's still a lot of work that we need to do to understand, and this is really a focus of a new work group that I'm leading through the CCNA about patient experiences with telemedicine and how acceptable and how feasible it is. It's also, I think, suggested that we embed remote assessment technology into dementia resources, into dementia research, so that we can better understand the validity of this.
Maiya, I will have to rush you. I'm sorry.
No problem. This is my last slide. And then just strategies to minimize risks and burdens of remote cognitive assessment to patients and caregivers. So thank you so much for the invitation, and it's a pleasure to be here.
Thank you very much, Maiya. That was an incredibly rich presentation, which I would suggest to all of you to watch again and absorb the slides, which can be circulated after the webinar as well. There's a lot there around best practice, and clearly the Montreal team is leading us in a very interesting direction. Now, there are people on this webinar who will come from the medical profession, which I'm sure will have taken a lot, but also for people who are carers, who are people living with dementia themselves. It's also interesting to have an insight about how complex best practice is at this moment in time in this discipline. And I think Maiya has really given us a great example of that. Now, it is my great pleasure to introduce you to Dr. Chandra. Mina Chandra is the head of Department of Psychiatry in the Center of Excellence in Mental Health in Delhi, India. One of my very first experiences of telemedicine was watching a great example in India, where I finally realized also the complexity, because in some of the cities in India, there may be specialists, but the issue is that the cities are so full of traffic and so complex that people can't actually physically, even there being specialists, can't actually get to the hospitals in time. And it just reminds you that ultimately this is about people, and it's all about how do you get people to help other people. And so it's with great pleasure, Mina, that I pass you the floor. The floor is yours.
Thank you so much to the area organizers, and without much delay, I would want to share my experience of using telemedicine. Though I'm a doctor, but from a care perspective, I'll be speaking on implementation, impact, challenges, and possibilities. Next slide, please. So when we implemented telemedicine services for dementia care in my center and also in the city, we decided that there were three verticals that we should focus on. One was the teleconsultation, the second was teleassessments, and third was teleinterventions. So teleconsultations, there were two models. One was consultation directly with the person with dementia or a possible dementia or a carer or both. And the second model, which we have followed largely, is a consultation liaison model in which we are not directly interacting with the patient, especially during the first visit. We are actually interacting with the GP or physician at one end and a psychiatrist and neurologist at another end. For follow-up, yes, we are very happy to do follow-up consultations and issue online prescriptions directly to the person with dementia or the carer. So these are the two models we thought about teleconsultation. Regarding tele-interventions, we went both for individual interventions and also group interventions, both for person with dementia and also for the carers. Next slide, please. So we have been doing some structured tele-assessments. They include the TMOCA, the Telephonic Cognitive Assessment by Pendlebury et al. Came back way back in 2013, but we realized its utility largely during the pandemic. 3 items, very easy to do, at least gives a good screen. And we have also been doing cognitive assessments on video calling using standardized measures as MMSE and MOCA, and having either a nurse or a general practitioner or a family as a co-therapist at the other end with the person with dementia. And we have also been interviewing carers for functional assessment, both for ADL, activities of daily living, and instrumental activities of daily living. And we developed an Android-based assessment, which is the Department of Science and Technology app for cognition. This is based on the 1066 protocol for assessing dementia given by Martin Prince. Regarding tele-interventions, we were already doing implementation research on cognitive stimulation therapy, led by Spector et al. When the pandemic struck. So we had to go virtual because we were in the middle of the trial, and thereafter we have given VCST as a clinical service delivery. We also provide supportive psychotherapy for person with dementia and their carers. We've also been given grief therapy, because a lot of person with dementia or their carers lost family members, and then apart from cognition and neuropsychiatric symptoms, grief became a major issue. So we had to evolve as the situation was changing. We also were in the process of adapting START program by Livingston et al. These are strategies for caregivers to deal with person with dementia. We developed a Hindi version and validated it, and then we started implementing it virtually because there was no other option. Then mindfulness intervention we had already devised for persons with diabetes mellitus as part of another service delivery. We started using its audio recordings. We started sharing the audio recordings, started training people on mindfulness, and we would share audio recordings and even animation videos on WhatsApp so that they could aid the mindfulness practice. And with help from Central Council for Yoga and Naturopathy, we started online yoga sessions just to increase mobility, flexibility, balance issues. And yoga has a lot of acceptability in Eastern cultures. So we are doing live online sessions on Zoom and Google Meet platforms. And we are also sharing some animation and actual videos on WhatsApp. And we are trying to see whether this works. And so far, the response has been very heartening and positive. Next slide, please. So the challenges that we face were, as others also suggested, logistics and infrastructure, especially in LMICs and LICs. We are currently providing intervention to patients who have moved back to their hometown, some 1,000 kilometers away because of COVID and lockdowns and loss of jobs of their carers. And in their hometowns, the connectivity issue would be there. The lack of digital literacy and awareness with the patient, that is very common. Thankfully, we are very fortunate to have family as a carer and family as a co-therapist. Most of our patients are staying in the community and not in nursing homes. And the family members, because they are aware digitally and they are want to contribute, so that challenge is surmounted. Then there was initial skepticism about virtual consultation, virtual follow-up, both by patients with dementia and carers. Later on, they found it so useful they started insisting only for virtual and not for in-person. So as the waves of pandemic would subside, we would start scheduling in-person appointment. And if the patient was stable, the carers didn't want to bring them. They said, no, you give virtual consultations only. If the patient destabilizes, then only we want to come. So the acceptability has enhanced enormously in the past 2 years. There are no dementia specific platforms. So how the patients came to be in the virtual sector was they were already consulting a neurologist or a psychiatrist, and then they were offered. But if a patient was staying in the community and he felt that he had memory issues, he didn't know how to approach for virtual consult or virtual Q&A session, virtual screening. So at the level of the public, they didn't know how to get onto the virtual platforms because there were no specific platforms. Then how to facilitate medication availability, because a lot of drugs are restricted.
We seem to have lost Mina. I suggest that we wait a minute. In the meantime, could I please remind everybody that we will have a Q&A session at the end, and it would be really useful if you started typing your questions in the Q&A box. Some of the questions have already been answered. Some of them are broader, and I may ask more than one of the speakers to respond to them. Mina, are you back now online?
Yes, I'm back. I think there was some connectivity issue.
No worry. Please continue.
May I have the next slide? Next slide, please. To reach out to the people, and especially because there's a lot of stigma and culture of silence about dementia, we started doing virtual awareness drives. This is not strictly telemedicine, but every step helps when it comes to a carer perspective. When we started speaking on dementia, the biopsychosocial impact, treatment modalities, and need for regular follow-up, then our follow-up enhanced. So that was fantastic. May I have the next slide? So we have a 95% treatment gap for dementia care, just like Dr. Ismael Calandri. COVID-19 provided an impetus to use telemedicine in dementia care. Now there is better accessibility, better affordability, less inconvenient. It has reduced the burden on tertiary care facilities. There's co-therapists during the virtual sessions with the consent of the patient, of course. It has reduced the sense of self-isolation because person with dementia were high-risk group for COVID-19, so they could not move out. And all in all, it has enhanced the health equity. Next slide, please. So the possibilities for the future are that we can have an affordable and accessible multi-dementia care model for person with dementia using telemedicine, not as a standalone option, but as a supportive and adjunct option. Now we can have a range of non-pharmacological interventions because many patients and carers have taken interventions in several online programs. Like they took CST, they also enrolled for mindfulness after they finished CST. They are now enrolled for yoga. The carers have now enrolled for START program. So there is a lot of acceptability as a family unit for tele-interventions. I think like Dr. Maiya, I would say that we have to start training researchers and students for virtual assessment, because this is the way medicine will move forward. And then we have to develop some inter-rater reliability protocols. And all in all, there'll be a reduced treatment gap if we start employing telemedicine. Next slide, please. And that is where I am. Thank you so much.
Mina, thank you so much. I know that you also had some video that you really wanted to show us. Because of timing, we'll see if we have some time at the end, but also the connectivity, I'm a little bit worried that we may have issues with that. These videos, Mina, if you have a link in YouTube or some other platform where people can see them, may be very interesting and complement what you have been talking about. A lot of what you say really struck me, because there is a theme that is really developing here. A lot of you have mentioned it, of a reluctance before COVID in using telemedicine, and actually during COVID, a great reliance on telemedicine as a better way, a less disruptive way for the patient to actually take part. But I'm wondering, especially in consideration of some of the comments of Henry and Joe, whether we may want to discuss at the end in the Q&A, and I invite more people to put questions on the complex issue of whether then we are talking about telemedicine being more complex at the stage of a first diagnosis and the communication of that, and more useful when we are talking instead of post-diagnostic support and critical but routine kind of reassessments and following up of patients, which we also know from previous webinars is a challenge in many countries, where some of the people living with dementia who have spoken at this webinar before have talked about a complete lack of follow-up. So you're getting diagnosed and then nothing happens, which is also why the World Alzheimer's report is going to be on post-diagnostic. Thank you, Mina. A lot to think about. Now, I really welcome Dr. Temitope Farombi, who is a consultant neurologist in Nigeria. Now, Temitope, as you will have seen from the chat, there is plenty of people following us today from Africa, your continent. But also there is a lot of people that are really interested about the kind of challenges that you must have had in Nigeria, which is a country that has so many issues and is again huge, like Argentina, like what Ismael was talking about at the beginning. So Temitope, the floor is yours. You may want to unmute yourself. Welcome.
Thank you for having me, and thank you, ADI, for organizing this webinar. My name is Temitope Farombi. I'm a consultant neurologist, and also I am a founder of a telemedicine platform, and I'll be talking from that point about our personal experience in establishing telemedicine in Nigeria. Slide.
Jane, there may be issues with the slide advance. Let us know. There we go. Thank you so much.
Okay, thank you. I think I can control it from there. I'm sure if I have the option. Okay. If I can't, I'll say next slide. So I'll be talking about the use of telemedicine for care and the future in Nigeria. Next slide.
Temitope, I think we have some problem with your microphone. So if you could speak a little bit more directly in the microphone, that would be lovely. Thank you.
Okay, thank you. Can you hear me now?
Yes, much better. Thank you so much.
Okay, yeah. I could say that the issue of telemedicine was first introduced to Nigeria about 15 years or more ago by the Federal Ministry of Science and Technology in collaboration with the Federal Ministry of Health, and it was piloted across 6 geopolitical zones in Nigeria. However, the project failed before it started. Why? Because there was lack of funding and also institutional framework. While we were still battling with our failures, other countries have lashed on the huge potential in telemedicine would offer, but we are still yet to key into the beauty of what telemedicine has to offer. Next slide. Okay. So, however, it was reintroduced back into the system, but this time around was introduced by private individuals who see the need in bringing telemedicine, using technology to improve the care service for people. And what has really helped in improving the uptake of telemedicine since 2015, that's about 8 years ago, is as a result of increased penetrance of telecommunication gadgets in the country. Currently, right now, Nigeria has over 180 million people using telephone. And of these 180 million people, 40 million, over 40 million have smartphone and also with access to internet. Of course, there's increased improvement in the penetration of internet access from 23.7 to 47.2. Right now, it's increased over to 50, a little above 50. And this has put us on a path of growth and improved medical services if we could use the opportunity. However, because of the ongoing pandemic, it then makes the need for telemedicine very apparent. Next slide. Okay, like what happened during COVID-19? Our hospitals were shut. There were no alternative provided, even because this number of hospital beds by 1,000. To see that in Nigeria, we were among even the countries in Africa with lowest admission into the hospital, as well as Ghana. So our hospitals were shut to patients, and this is largely due to logistic problem. There were no access to PPEs, and the doctors health workers were getting infected. There was no access, there was no way to treat patients, and there was also a huge stigma surrounding COVID-19. Such people were not coming out. The aftermath effect of this was those who were already living with chronic diseases like hypertension, diabetes, dementia, were locked out of hospitals, and there was no way we could reach them. So, and people don't know that these opportunities were available for them. So they couldn't even know where to turn to. Of course, we have a lack of understanding. Our doctors are not sure if we want to do the part of use of virtual care to support patients, except for use of telephone instead of video conferencing. Then there's huge infrastructural deficit, problem with electricity, problem with setting up of masks, and also high cost of data usage. Of course, a lot of doctors and a lot of healthcare professionals still want to do the usual face-to-face consultation. And also data protection was an issue, protection and use of social media. So these are just few of the many more challenges that we were facing, despite people dying from non-COVID cases as a result of the aftermath effect of shutdown from COVID. So what we then did was because I personally work in the hospital and I have a lot of older adults that are my patients, and they couldn't reach us because the hospitals were shut down. They were not bringing them in because we said that all the older adults should stay back because we think that they won't be able to mount immune response to fight the COVID. So they were locked out. So what did we do? I decided to set up a platform for telemedicine. Next slide. Next slide, please. Okay. So, like I said, our hospitals beds were empty because there was no way we could assess patients. And they couldn't come out. They are scared that they will get infected while in the hospital. And we didn't have enough PPEs to protect our healthcare workers. Also, you can see a patient here, even the ones that were diagnosed to have COVID-19, were abandoned in the hospital because they could not be reached physically because of lack of PPEs. So this telemedicine is an option for us. Next slide.
Next slide, yeah.
Okay.
And Temitope, I will need, much as this is very interesting, I'll need you to rush a little bit through the presentation because we are coming to the end of your slot. Thank you.
Thank you. Yeah. So this is a model telehealth provider in Nigeria. One of it is O Health, which I founded. It's an online platform that allows online consultation, electronic prescription, electronic medical record. You can actually do online pharmacy and also do a virtual lab by booking your laboratory request. from your mobile phone. This was started in September 2020, even in the heat of the COVID. Next slide, please. So these are the sample use. You can see this is one of my patients here who we were able to use telemedicine to consult while in the comfort of our home. And we're able to take it to also the rural places and get individuals to support the platform such that people can walk in close to their home to have a teleconsultation with doctors, and even in the urban center. So far so good. We've been able to have 12,000 people coming on this platform with over 100 doctors and across 28 specialties. And we've done over 35,000 consultations on the platform. And these are giving us a lot of feedback and also open our eyes to the possibility that telemedicine has to offer. Next slide. So, but of course, we still have challenges, like every other person has said. We're not patient satisfaction. Majorly is the connectivity, problem with poor connectivity. So while they are doing virtual consultation with the clinician, there might be poor connectivity and don't be able to hear themselves. And also that might actually tune them off from adopting this, even though we've got a lot of feedback and patient feels they are better they feel better staying in their own comfort zone to be able to be attended to. Of course, other challenges that we have experienced is clinician burnout. They having attend patient physically. Of course, the burnout that comes with use of virtual, they attend other meetings virtually, and now they are seeing their patient virtually. Of course, poor digital literacy, and also poor adaptability by organization, especially integration of hospitals and licensing, privacy, and also medical legal issues. These are the challenges that we're facing right now. But of course, it's better that we start and then we can also surmount it as we go. Next slide. So this is what the platform looks like. From your mobile phone or your laptop, you can do virtual consultation with specialist doctors. Of course, I am constantly on the platform as a neurologist to attend to my clients. Of course, we have geriatricians on the platform, and we've seen the possibility that this telemedicine has to offer. If we have everybody on ground, the government, we have medical buy-in, and also increase accessibility to internet infrastructure. And this has capability to revolutionize our healthcare system in Africa. Right now, most of those who have access to internet are in the urban city, and about 74% of Nigerian population live in the rural community with no access to internet. And if well done, it can improve and can become a game changer in solving our health challenges. Like I said earlier, there's still a long way to go, but it's a baby step that is worth emulating. Next slide. Thank you.
Thank you, Temitope. Very interesting. And again, another country where a lot of progress has been made on telemedicine, where before there was so little. So once again, I'm inviting your question, please, because we will have a few minutes at the end to answer them. A quick poll from us at the end of this series of presentation to ask you, where do you see the biggest growth in the use of telemedicine? For initial consultation, for diagnosis, for follow-up consultations, and or for care support? Could you take, please, a few seconds to answer? We will do it very quickly as we do not have a lot of time for questions. And we should now start the results in a second, as soon as James receives some of your answers. So for initial consultation, 41% of you think about that, less so convinced around diagnosis. And certainly for follow-up consultation and care support, it seems to be a great choice. So we'll close this poll now. I'll go to the Q&A box. There are some really interesting questions. Now, I will call on Henry to answer this one. We have yet to see the consequences of 2 years COVID and forced telemedicine. How many cases of cancer, heart condition, dementia have we diagnosed too late or missed completely? Telemedicine is here to stay, but how we will monitor its progression, success? Henry, please.
I think there are good data now to show that people have been delaying their assessments. You look at breast cancer screening, rates dropped considerably during the times of COVID. So there are data to suggest that people are getting their cancers diagnosed later with poorer consequences. So it's an excellent question, and it highlights a problem with COVID rather than with telemedicine. And the other thing is people not having some of their conditions monitored as they should as well. For example, diabetes. Maiya, I think, may have more data on that from Canada.
Maiya, do you want to jump in? I also have another question for you here, which is what do most clinicians do if they see abuse or neglect during a telemedicine visit? Which I would also like to ask briefly Mina to reply to.
Yeah, so if we see an abuse happening during a telemedicine, we are a center of excellence. So we have multidisciplinary team of social workers, clinical psychologists. They just take over. We also, with prior consent, record the consult. So we have the recording, and also of the abuse. If it happens during the consult, we have the recording. So our team goes, visits, and tries to psychoeducate the family about dementia, its difficulties, neuropsychiatric issues, try to have a facilitative role rather than a blame-giving role. Because sometimes the family is burnout. So, and in some cases, we had to seek help of police as well. So that is another side too.
Of course, tricky one, that one. Maiya, on both questions, please.
Yeah, so in terms of risk or abuse seen during a telemedicine visit, I mean, one of the advantages of telemedicine is that you're actually doing sort of a home visit in a way. So you're actually seeing people's home environment. And I actually think we haven't fully utilized that piece of what a video conference telemedicine assessment can offer yet. So we sort of see this accidentally, but we might consider doing it more systematically in the future. If there's sort of imminent risk, it's actually important to know where the patient is located. So at the outset of a video conference assessment, this was actually the story of Joanna's. She was traveling and the physician or the clinician didn't know where she was. So it's actually important to know where the patient is when you start your visit. In fact, you're not actually compensated if patients are outside of your jurisdiction. But being able to actually call sort of emergency services to that location if that's warranted. In Canada, we have an elder abuse hotline and services that we would access to sort of help with that circumstance.
Thanks. And Maiya, do you want to follow up on the question that was asked of Henry, the one about the 2 years of COVID?
Yeah, so I agree with Henry about this is a COVID problem as well as possibly a telemedicine problem. So it's a combination of both. So certainly there's data emerging that COVID has delayed diagnoses across the board, whether that's, as mentioned in the question, cancer diagnoses or dementia diagnoses. Telemedicine has sort of this advantage of being able to help people access care who might not otherwise access care. So there's probably a slice of the population who'd get diagnosed through telemedicine that might not otherwise have, but it's a very complex problem and one that we're going to learn more about. But the answer is we have to continue to monitor and continue to do research on this. It's an evolving and dynamic problem.
Thank you so much. We have a lot of questions. I want to focus on this question and I want to ask first, please, Temitope, quickly, because we really do not have a lot of time. And Ismael, if they could answer this also because of their areas, which is whether you know if there are apps, any free cognitive assessment mobile apps available. I'll ask you two first and then I'll ask Henry to come in on this. Thank you.
By my experience, I just can tell you that be careful with apps. I think we have to select these apps that show evidence in cognitive evaluation. That it's a very, very tiny field. No, my suggestions and the way that we apply in Argentina, it's just to use our regular neuropsychological work and transform and adapt to do the assessment. But it's just a new kind of assessment, but it's made by an expert. It's not automatically, it's not with an app. And my words is that maybe that is the better way to do that. Apps can work, computers are evolving all the time, machine learning, artificial intelligence is moving forward to diagnosis, but I think it's too early for give the computers to do by alone.
Ismael, I'll have to stop you there, unfortunately, because we've run out of time. So this is all the time we had today. I thank Henry for Mina and Maiya and Ismael, Temitope and Joe that shared their story with us for their contribution. Some of our speakers have been writing answers to your questions in the Q&A box themselves, and we do collect the questions so we may be able to ask the speaker to reply to some of you in person after the webinar. So thank you very much as ever for following us, for following what we do at Alzheimer's Disease International, and thank you for being with us from, as I said, 78 countries. We'll see you soon again for another webinar. We'll let you know when that is, and you will be able to find the recording to this one and share it more widely from tomorrow. Thank you so much, and thank you for being with us. Goodbye.